Hi there, my name is Lauren Forster, and this summer I had the opportunity to work as a Flint Fellow at the Hospital of the University of Pennsylvania on 12 campus, which is mainly a solid oncology floor, and I go to the University of Pennsylvania School of Nursing. So for my evidence-based practice project, I decided to look into the use of aromatherapy as first-line treatment in chemo-induced nausea and vomiting. Something that was very common on my floor and I saw pretty much every single time that I was there. So I'll get into a little bit why I chose this topic. So to give you just a little bit of background, chemo-induced nausea and vomiting, or CINV, is one of the most common intolerable adverse events that's associated with chemotherapy. It is well known that it can impede and sometimes even interrupt chemotherapy treatment regimens, as it can cause physical disturbances to our patients, such as fluid and electrolyte imbalance, dehydration, anorexia, weight loss, as well as hinder their social lives and sometimes even prevent them from performing their own ADLs. Ultimately, from a nursing perspective, this is something that can extend hospital stays, and it can also lead to worsened hospital outcomes. So this is why I decided to look into it, was because I noticed it was something that was very common on my floor, and I wondered if this was potentially something that was keeping our patients in the hospital. And so there's a few different ways we can classify CINV. Acute onset being chemo-induced nausea vomiting that occurs within 24 hours of chemotherapy administration. Delayed onset being about 24 hours to 5 days after chemotherapy administration. And then anticipatory chemo-induced nausea and vomiting refers back to this concept of classical conditioning, and that maybe a patient experienced a negative outcome and had an emesis episode after their first cycle of chemotherapy, and now they're kind of anticipating that it will happen again. So I also just want to touch on this concept of emetogenic potential. So emetogenic potential refers to the potential to make the patient have an emesis episode. So different chemo agents have different emetogenic potentials, ranging anywhere from minimal, low, moderate, to even high emetogenic potential. Lastly, antiemetics. Two very common ones that I saw on my floor were Zofran and Compazine. And these antiemetics, while they're very helpful and they have been proven to successfully help manage chemotherapy-induced nausea and vomiting, they haven't been shown that they can completely control these adverse side effects on their own. And so, additionally, these antiemetics can have certain negative side effects, such as heartburn, insomnia, headache, constipation and diarrhea, things that can, once they occur, these patients are already experiencing a lot of negative side effects from the chemotherapy, and to compound that with the side effects of antiemetics, it might put them in worse shape than they were before. So while they are maybe getting a little bit of relief from that nausea and vomiting, they may also be experiencing some other side effects that they don't want to be. So that's kind of why I decided to look into this topic a little bit further and explore aromatherapy as a first-line treatment option. So on that note, aromatherapy is the therapeutic use of essential oils. It has been shown to have a positive impact on a variety of both physical and emotional conditions. And specifically at HUP, it is a nurse-driven practice. And so what that means is that the nurses get to decide when aromatherapy is implemented and kind of the ins and outs of it, which is something that's really cool. Additionally, aromatherapy doesn't have the same side effects that I previously mentioned that some antiemetics do. So that's kind of a benefit to it, that it might prevent compounding those several other side effects that they might be experiencing from the chemotherapy. So at Penn, we have a few different types of aromatherapies, one of them being Reiki therapy and massage therapy. This is something that I actually got to see at the Perelman Center of Advanced Medicine when I was on the outpatient infusion unit. This refers to a gentle, completely non-invasive practice that promotes balance and well-being and involves the light touch of the practitioner's hands on or slightly above the patient's body. And so I actually got to see this be implemented while the patient was receiving their chemotherapy, and it was a really cool practice, very calming, and also involved the use of aromatherapy. And so we also offer smell sticks or sniffers on the floor. We have ginger and peppermint, which are supposed to help lessen patients' nausea. We also have lavender that can also lessen nausea, but additionally can reduce anxiety or stress for our patients. We also offer lavender hand massage, combining gentle massage therapy with aromatherapy. But this is often, along with the Reiki and massage therapy, something that we see more on the outpatient basis, especially due to COVID. So given all of that background information, I decided to pose the question, what is the role of aromatherapy in reducing chemotherapy-induced nausea and vomiting in oncology patients compared to pharmacologic measures? So here my population was oncology patients. My intervention was aromatherapy, either diffusers or inhalation. And then the comparison group was pharmacological therapy, so antiemetics such as Zofran or Compazine. And then the outcome being reduction in chemotherapy-induced nausea and vomiting. So I decided to look at a few different studies. One of the first studies that I looked at was one that explored the use of peppermint oil. So in this particular study, the intervention was 1 drop of aromatic mixture, so the peppermint oil, between the patient's upper lip and their nose about 3 times a day for 5 days following the administration of chemotherapy. This study ended up finding that the peppermint oil significantly reduced the frequency of nausea, vomiting, and retching, and the severity of nausea using 2 different scores. So I will touch on now how they decided to measure these different indexes. So they used 2 different scores. The visual analog score, which is something that we often see with pain scores as well. So kind of similar to our Wong-Baker FACES scale, patients will kind of point to where they're feeling their nausea lies on this scale using the photos. And that gives us something that we can quantify it with. And then we also have the index of nausea, vomiting, and retching, which, as you can see here, is a series of 8 questions in which patients rate and they assign a numeric value from 0 to 4 for every single question regarding their nausea and vomiting. So this study specifically used both of those scoring systems in order to quantify their data, and they found that peppermint oil significantly reduced the frequency and that the concurrent use of peppermint oil alongside antiemetics after chemotherapy administration that had low to moderate emetic risk is beneficial in coping with chemo-induced nausea, vomiting. So this was interesting just because it used both the antiemetics as well as the aromatherapy rather than just one or the other. So given that, I decided to kind of do a little bit more research, and I looked at this study that explored breast cancer patients, and it was a single-blind controlled randomized crossover study. So in this scenario, we had a 5-day aromatherapy treatment. Either the patients received either a fragrance-matched artificial placebo, or they received a ginger essential oil that was instilled in a necklace that they actually wore. So same kind of analog score. We use the VAS here again. And in this study, the VAS score for those who received the actual intervention, so the ginger essential oil inhalation, was much lower compared to the placebo in the acute phase. So that 24 hours to 1 to 3 days after chemotherapy administration, the VAS score was significantly lower. However, it was not sustained over a long period of time. So it also had no significant effect on vomiting. But this study just kind of demonstrated that ginger inhalation on its own can be used as a frontline therapy in the acute phase of treatment. So then I decided to look at another study that kind of explored the use of massage as well, because that's something that's implemented at HUP. So this study looked at 3 different interventions that occurred before the 2nd, 3rd, and 4th chemotherapy cycles, one being a 20-minute aromatherapy foot massage and the 20 minutes before chemo. The second group being a 3-minute inhalation aromatherapy 5 minutes before, which was a cotton sponge that was soaked in a variety of different oils, and then they inhaled it for the 3 minutes before chemotherapy administration. And then lastly, the control group. So what we found in this study, or what the researchers found in this study rather, was that there was a statistically significant relationship between the groups experiencing nausea and retching between the 3rd and 4th cycle of chemotherapy. and that the incidence of nausea and retching was significantly higher in the control group than in the other groups in the third and the fourth cycles. They also found that nausea severity was significantly lower amongst groups 1 and 2, those who received the interventions, rather than group 3 in all 3 cycles. So this study really drove the point home that non-pharmacological approaches can actually adequately control and prevent that chemotherapy-induced nausea and vomiting. The last study that I decided to look at was the use of lemon oil pads. And so in this study, the intervention referred to 2 drops of lemon oil that were applied on cotton pads. They were clipped to the patient's clothes or given to the patient to use as needed. And so this study ended up finding that adequate relief for nausea and vomiting was reported for about 73% of applications, which is a great number, and about 27% reported no symptom control. So this was a really great study because it really demonstrated again, like as the last one did, that aromatherapy works as a frontline therapy for the majority, and it can be used, and it should be used as a frontline and then progress it to antiemetics, so that we prevent patients from having those negative side effects of antiemetics that you can see here and that I listed before. So this kind of really drove home that maybe we should be exploring these non-pharmacological methods first before we subject our patients to some of the negative side effects that can kind of compound and increase their hospital stay that are associated with those antiemetics. And so given all of that research that I did, some clinical recommendations that I gathered were just that further research needs to be done on the inpatient setting to continue exploring the benefits and to strengthen the current evidence that aromatherapy is an adequate frontline therapy for a lot of patients and should be used as a frontline therapy before we jump to those antiemetics and those pharmacological interventions. Also, just obviously the implementation of more aromatherapy in the acute care setting. There can be some other ways that it's implemented other than just those sniffers that I mentioned, and we should be offering them to patients more frequently. Training and education for nurses and providers is also very important. A lot of nurses and providers don't understand or know the benefits that aromatherapy can have. I also think we should incorporate other holistic medicinal techniques into symptom management. Bringing that Reiki massage therapy back to the inpatient setting, I think, would be really important in helping these patients control their symptoms. Additionally, controlled trials to determine when aromatherapy is most beneficial. Some studies looked at it using it before the chemotherapy cycle was started, and some of them looked at it after the chemotherapy cycle was started. So these further controlled trials to determine at what point the aromatherapy would be most beneficial, I think would really assist in answering this question. Lastly, I think it's really important to understand that pharmacological measures are not the only treatment option, and they don't always need to be the first line option for our patients, as they can cause, prolong their stay in the hospital and cause further issues for them. So with that, these are my references, and I just want to say a thank you to Mr. Fred Flynn, Kristen Maloney, Jordan Mellinger, HUP Pavilion 12 campus nursing staff for helping me throughout the way, Maeve Gilhooly, who was my interim assistant nurse manager, Jess Caro, who coordinated the Flynn Fellowship, scheduling for all of us, and then Kristen Hill, my nurse manager, and Rachel, my clinical practice leader for 12 campus. Thank you so much. This was a wonderful experience and something that I will always remember, and definitely has helped my nursing skills a lot, and I'm forever grateful for it. So thank you.